Hello and welcome to another session of OmegaMatters, where we talk all things Omega. My name is Bill Harris. Normally, I'm joined by my daughter, Kristina Jackson, but she is dealing with a sick child today, so life happens. So I'm going to handle our discussion with our guest, Grant Franco. Grant is working with the O'Keefe Group in Kansas City at the Mid-America Heart Institute. He is a MD and just about ready to continue some of his training at WashU in St. Louis. Many times we interview like the most senior people in the field, and sometimes we get to interview some of the up-and-coming field researchers, and I think that's what Grant represents here. So welcome, Grant, and we'll have a talk about the PCE, which we'll get to in a moment.
Yeah, super excited to be here. Just quick correction, I'm going to be going to St. Mary's Hospital in St. Louis, not WashU, but I'll be right near there, just but I'm super excited to be here. I'm excited about the research we've been doing and really grateful to kind of learn a lot from you guys, because you guys are real resources and teaching me how to get write a paper, get a paper published, how to respond to all the stuff that you have to do to really become a prolific researcher like you guys are, and you are. So, thank you.
Yeah, well, you got to learn the ropes. There are certain skills for writing and publishing and reviewing and responding to editors' questions and revising. It's quite a process, and you did a great job on this paper. The paper we're going to talk about today, I think I'll just bring up a picture of it. This is the paper. It's a brand new paper, and it's published in the Journal of Clinical Lipidology, one of the best. It's a fairly young journal in a way, but it's really a very good one. And we published in it before. There's William G., go by Grant, though, right?
Yes. Yeah.
Your middle name, along with our other investigators. And the title is "The Omega-3 Index Improves Upon the Pooled Cohort Equation in Predicting Risk for CVD." So that is the topic. So introduce us to the idea and what we did.
Yeah. So the idea is there's a paper that I believe you worked on about 15 years ago that looked at this Framingham risk score, which is kind of a using different risk factors to predict risk of developing cardiovascular disease, and particularly coronary disease. And it looking at a real kind of advanced lipid suite and see how that did for predicting CVD versus the Framingham risk score. And so the general idea of the paper was to see how, a omega-3 index, or like a blood level of our like omega-3 levels, and how that did fitting into the most current risk score, which is the pooled cohort equation. A little background, I guess, about these risk scores is, a lot of people have heard of the, Framingham heart study, which essentially looked at followed the health of the members of this town over like a incredibly long period of time. And it looked at different risk factors for kind of developing coronary disease, coronary disease meaning, like having a heart attack or angina or something like that. And, looked at those different risk factors and kind of seeing how we could develop a risk, like a 10-year risk for somebody of having an acute coronary event, which would be like a heart attack or something like that. And so that's where we kind of developed our thoughts about cholesterol, and it's like this has been a very important thing. And so we developed this risk score that came out in 1998. And it's been iterated on. Framingham, Massachusetts was kind of like not the most diverse place, and so we've been iterating on this Framingham risk score to be more inclusive of different ages and different, socioeconomic backgrounds, racial backgrounds. And eventually in 2014, we developed the pooled cohort equation, which is kind of a expanded upon risk score, which has been incredibly useful at developing a 10-year risk for having a coronary, developing coronary heart disease in 10 years. And like the the idea of this risk is, you look at like if you're smoking, if you have diabetes, like your total cholesterol and your systolic blood pressure, like all these important things. And so our idea was like, how, like, can omega-3 index make this score better? It's, this is a very important score for determining if somebody who doesn't have coronary disease, if we're going to put them on a statin or not, or are we going to treat cholesterol, and particularly if somebody is like right between 7.5 and 10, percent risk of having an event in a 10-year period, it's like you go on a statin, that's kind of how it goes. And so, if we can even improve upon that a little bit, or we have some kind of tool to further discriminate risk, then that could be really helpful for clinicians, and particularly omega-3 index, because it's an incredible, it's like, I like to talk about it as low-hanging fruit, because like, when we're talking about somebody going on a statin or blood pressure, these are things that usually are not, while they're incredibly helpful, they're not entirely benign, and oftentimes, consuming more fish, supplementing with high quality omega-3, these are rather benign things that can be incredibly helpful for people in their like long-term health and long-term risk of developing coronary disease. So that was kind of the thesis and the idea. And I feel really fortunate to be able to work with you guys and have access to incredibly talented biostatisticians that have been able to work out like this, work out exactly how this fits in. And we used a couple of the Framingham cohorts, the initial ones. I don't know if it's necessary to tell you all of them, but, we used those initial cohorts and kind of figured out that the omega-3 index is actually a really powerful, and predictive tool for seeing if somebody's going to have develop coronary disease. And it's interesting. A lot of the risk factors that they use in this score are kind of dependent on each other in a way. And oftentimes when we did this study, and we found that omega-3 is actually this really powerful independent risk, risk predictor. And
what are the components of the pooled cohort equation to begin with?
Yeah. So it starts off with age, and age is like this incredibly, like shockingly important risk stratifier. So age is the first and most important one, age and sex, but really age. And then after that, there's systolic blood pressure. So that's how well your blood pressure is controlled. If you're on blood pressure medication, your total cholesterol, and then if you have familial hypercholesterolemia, so if your LDL is incredibly high, also if you have diabetes, if you smoke, and your race is included, but it's actually not very important in terms of like the risk score itself. So those are the main.
Isn't HDL cholesterol?
Yes, HDL cholesterol. HDL cholesterol is really important. I thank you for mentioning that one, because it's really important, but it's not very changeable. It's good for determining risk, but like we don't have a lot of advice how to get somebody's HDL from 40 to 60.
Right.
And so, but omega-3 index is modifiable. And so that's why it's kind of an interesting thing to, look at.
Yeah. So I think as we did this paper, I think we were all maybe not surprised, but it was quite an eye opener to see how much of the risk prediction is just driven by age.
Oh yeah.
And these other 6 or 7 factors that you just went through, add a little bit, but I think we forget that they're only adding a little bit of predictive value. And so when we added the omega-3 index, how much did it change the prediction?
So it kind of depends on how you add it in, but it significantly increased the prediction. I say there's a way that we, let me look here. It added on, depending on how you added it added on from you know, 1 to 2% predictive value, you know, in this area under curve, which is it's kind of it's hard to describe how we, you know, we validate the statistical, like statistically validate tests. We use like area under curve. So you have like how much of the total disease burden did the test capture? And so it essentially captured like like an additional 1 to 2%, depending on how you add it in. If you add it in initially right after age and sex, it captures more. But if you add it in at the end, it still captures a fair bit of that, you know, I guess relative change in AUC. Yeah. So
I mean, how does it compare to having a high cholesterol or
so you know,
for example,
compared to having a high cholesterol, you know, when you add it in after cholesterol, it's going to capture. So it captures about 4%, and when you add it in after age and sex, and if you add in total cholesterol, it captures 2%. So 2% extra. So it's actually capturing double the amount of cardiovascular risk over the, you know, 10 years when compared to total cholesterol, you know.
So, and that, I mean, we should just probably stop and marinate on that for a minute, because I think most people, you ask them what are the big risk factors for heart disease, and they don't say age, they don't say sex, they say cholesterol.
Yeah.
And maybe they say blood pressure, and that's what they know. But you found in your study that the omega-3 index was as or even more predictive of future risk for cardiovascular disease than cholesterol.
Exactly.
Which is, you know, a kind of a wake-up call, because people don't think about omega-3, as you mentioned, a very modifiable risk factor, as kind of running with the big dogs in a sense. You know, it's just as good or just as bad in a sense as the standard risk factors. And so what would be the kind of takeaway from this? What, you know, I know you've expressed an interest in primary care, and how would this, you think, help out in a primary care setting?
You know, like I think the like accurate determination of risk for patients is really important. And like I kind of said, having an an easily modifiable, not like thing that we can change without, you know, adding on a medication that is exposing you to risk. Like, you know, a lot of people don't like taking statins, you know, and if somebody's like kind of in this borderline risk area and this like 7.5%, we could think about, you know, first of all, getting an omega-3 index, see how they're doing in terms of their like omega-3 level, and then think about adding on a fish oil supplement or omega-3 supplement on top of that. Or, you know, if somebody isn't as interested in that, making sure they're consuming more oily fish, like, you know, and like, you know, from like 0 to 1 to 2 to 3 times a week, you know, these things are actually really helpful for patients. And to be honest, patients like having options and having agency in their healthcare. And so, and having a discussion that isn't like, okay, like you can do a statin or not, is a important place, I think, to start for patients, you know? And so I think this is an incredibly powerful tool, and it can be really, you know, helpful in, you know, getting people on like a healthy track in terms of their diet, you know?
Yeah. I don't think you're saying this. You're not saying that fish oil would replace a statin.
Yeah, no, I'm not saying that. But what I am saying is that, well, because we're talking about like this narrow range of risk in the future, like looking at people's risk into the future, and so if, you know, raising their omega-3 index, say, like when we think about this, like you start somebody on a statin when they're between 7.5 and 10% risk in the pooled cohort equation. And if adding in, if they're in the lowest quartile in omega-3 index, and they don't want to do a statin, or maybe even their cholesterol is pretty well controlled, it's like they had pretty good cholesterol. And they're like worried about being in this, 7.5, say they're right at 7.6, on the pool cohort patient. I think giving a patient the agency to say, let's try a dietary, something that actually might help, and they don't want to do a statin, that's helpful. But also, being able to recommend, say they do want to do a statin, but they want to do more, but you can say like, this is actually really important, and can also help you on top of it. I think both things are important.
Yeah. I mean, it sounds like the same kind of approach you would take with somebody who's got high cholesterol and is a smoker. You'd say, well, there's two things we can do here. And should do, right?
Yeah.
Stop the smoking and deal with the cholesterol. And here you're saying if you got a low omega-3 index, that's a problem and it's fixable. It doesn't fix everything. But it's something you can do to improve your health and actually lower your risk score.
And to be clear, if it sounded like I didn't want to put somebody on a statin if they had high cholesterol, like it is like one of the things in my current role that I pride myself in is talking people through going on a statin when they're really scared to go on a statin. So it's like, I care about that, but I also really care about omega-3 index. And I think it's really important for people to, think about the types of, how the diversity of their kind of food consumption. If they're not eating fish, we should be supplementing omega-3. Most people are not eating enough fish, so most people should be supplementing omega-3, and so I think it's really important. In your research background, kind of research for doing this paper, did you find, I mean, we're talking about 10-year risk prediction. Right? And, someone would say, well, I like to know my 30-year risk prediction. Has anybody done something like that you know of? They are kind of like starting a new risk score that is, I don't know specifically how long I think it is 30-year risk. It's like it's a cardio kidney metabolic score, which I think they're starting to roll out, which is actually a very exciting, advancement, I think, in our risk prediction. And I think it's probably like the obvious future application of this research, but it's inclusive of more ages. So it's like the PCE, you start being able to calculate risk at 40 years, when somebody's 40 years old.
Age 40.
Younger, it's inclusive of metabolic disease, socioeconomic status, and, kidney disease, and because everything is so connected. So, and I believe that one predicts 10-year risk and 30-year risk. I hope that's not morbid.
It's hard to imagine how, from a baseline, today, predict your risk 30 years for a heart attack, and actually prove it, because you'd have to sort of not the people whose lives are used to make those equations. Theoretically have to live another 30 years, and they have to have not changed anything. Because if you stop smoking and fix your diabetes, get your blood pressure under control, your liver's under control, your omega-3 index, your risk really is going to be much lower than it was predicted to be. And you wouldn't know that unless you track them all the way through. It's a real challenge, I think, to look at these long-term predictors. And so you mentioned this, there's a new risk prediction that includes chronic kidney disease, which is interesting and reasonable. I guess the next step in this kind of research would be to take the omega-3 index and add it on top of this new predictive thing and see if it still predicts. Do you have any idea of what the mechanism by which the omega-3s are working is that would maybe explain why it adds additional predictive value above and beyond the other risk factors?
There's a number of mechanisms, and I know this is like your like total wheelhouse, but like when we think about when I think about omega-3 and what it does in terms of like overall, health and cardiovascular health, I think first about like the anti-inflammatory, properties it holds, and kind of modest antiplatelet properties. It's not like, I wouldn't say it's aspirin, but it has some modest antiplatelet properties, and so like.
Yeah, so what is that? What's an antiplatelet property mean for our audience?
Thank you. I sometimes I can use jargon. So antiplatelet, like one of the when you have a heart attack, what is happening? You have a plaque in your arteries, which is like a kind of inflammatory bulging out of your arteries that has like this rich lipid core, and it breaks off and it aggregates these platelets, which are the things that stop you from bleeding when you are if you are bleeding, and they're really important. You want platelets, but if you have a atherosclerotic plaque, which is that thing that causes heart attack, it breaks and then it aggregates all these platelets, and then you have a heart attack, and then you have the crushing chest pain. And so one of the first things they do when you have a heart attack is you take 325 milligrams of aspirin and you chew it, and it's one of these things that helps you. So kind of like how people take a baby aspirin, that's kind of having some amount of antiplatelet activity in your body. And I think, we can have a whole different discussion about that. There's a modest antiplatelet, activity with omega-3, and I think that probably helps a bit with these ASCVD events, or cardiovascular, these coronary events. And so, but also inflammatory disease, as I always talk about, this is how I explain it in our clinic to patients when people want to know what is a heart attack, what causes it. I kind of the example I use is like when you fall and skin your knee as a kid, you're running around outside, you skin your knee, you make a scab, like over that part that you skinned, and kind of like that, kind of the same thing happens in your arteries. When things damage your blood vessels, there's an immune reaction that happens, and you make this thing called an atherosclerotic plaque over that damage. And so things like high blood pressure, high cholesterol, smoking, diabetes, all these things damage your blood vessels. And chronic inflammation is one of those things that completely and totally damages your blood vessels. And having increasing your body's anti-inflammatory capacity through high omega-3 index will certainly help long-term risk, in terms of, developing these plaques in your arteries. And it also, and this is kind of secondary to, the risk of developing these plaques. Like also there is a lot of membrane health. When I think of omega-3, I think of membrane health and kind of increasing your cells' ability to work together and to receive signals and to get all the things that they need. And so it's kind of this like really holistic cellular health mechanism when I think about omega-3 and how it works. So those are kind of the things that I think about when I think about how omega-3 works. I know you're like completely, this is like your wheelhouse and what you've kind of devoted an incredible amount of time.
I like to hear other people explain it and make sure the message has gotten through
to
the next generation. I appreciate that.
Yeah.
Great. So, I think we've kind of talked about what our next study might look like. When and if we actually mount that, we'll of course be in touch, since you've kind of got this in your wheelhouse now, this kind of idea. And I know you'll be looking for more publications as you move through your medical training to advance your exactly.
Yeah.
So maybe we'll wrap it up there, and thank you for going over this important new paper. And we'll hope that the rest of the world has a chance to look at it and think about it. It's one of the troubles these days. There's so much information, you really don't get any information sometimes. And so we'll be promoting this. And for now, we'll just wish you the best in your career and your next step in training. And thank you for being with us on OmegaMatters.
Yeah. Thank you so much.
Take care. Take care. Bye-bye.